I'm here at ASCO 2017, where I recently presented the results of the BRIGHT trial. This was a long-term follow-up of this trial. The BRIGHT trial was a randomized phase 3 trial comparing bendamustine and rituximab to either R-CHOP or RCVP for patients with indolent lymphoma or mantle cell lymphoma. The basic design of this trial was that once a patient was deemed eligible for the trial, their treating physician had to choose a standard chemotherapy, either R-CHOP or RCVP, and then within those strata, the patients were randomized to receive that standard chemotherapy or bendamustine and rituximab. So we originally presented the complete remission rates in 2014. This was the primary endpoint of the study and was a non-inferiority design. In that 2014 publication, we demonstrated that bendamustine rituximab had a 31% complete remission rate compared to a 25% complete remission rate in the R-CHOP RCVP arm. Now, at this meeting, we presented the time to event analysis with 5 years of follow-up in these patients. So we presented the progression-free, the event-free, the duration of response, and the overall survival for patients. And what we saw in the patients with mantle cell lymphoma was that, like the population at large, that there was a statistically significant and numerically large improvement in event-free, progression-free survival in these patients, as well as duration of response. However, while there was a significant trend, there was not a difference in overall survival for patients with mantle cell lymphoma. So the overall survival is the same for this the patient population. So we conclude from this trial that that the toxicity is not very different than what we had seen before, with the possible exception of second malignancies. We did see an increase in second malignancies in patients who were treated with bendamustine rituximab compared to the R-CHOP RCVP. However, when we looked at this a little bit more closely, it turns out most of these second malignancies were either squamous cell carcinoma of the skin or basal cell carcinoma of the skin. So really not very invasive malignancies that can easily be dealt with. And we removed those from the analysis, as well as patients who had transformed lymphoma, which is most people would probably consider to be the just progression of the underlying disease. There was no longer a statistically significant difference between the two groups, although there was still numerically an increased number in the BR arm. And so I think that we conclude that BR is a very good option for patients with mantle cell lymphoma. It improves the complete remission rate, the overall response rate, the progression-free survival, the duration of response, and event-free survival for patients with mantle cell lymphoma. And I think it has a very good toxicity profile.